It was a humid summer morning when Mr. Thompson, a 58-year-old retired carpenter with diabetes, arrived at the clinic, leaning heavily on his cane. His wife, visibly worried, helped him into the examination room. "This ulcer just won't heal," he said, removing his shoe to reveal a wound on his left foot. The ulcer was surrounded by redness and swelling, with a slight purulent discharge. It had been 2 weeks since it first appeared, but instead of healing, it had worsened. Dr. Carter, a thoughtful and experienced physician, examined the wound closely. The erythema extended more than 2 centimeters around the ulcer, with visible swelling and tenderness. Despite the localized infection, there were no signs of systemic toxicity, no fever, chills, or confusion. After completing his assessment, Dr. Carter explained, "This is a moderate diabetic foot infection. The good news is that we caught it early, and with the right care, we can manage this effectively." Dr. Carter began by explaining the steps they would take. "First, we'll take a swab of the wound for culture to identify the specific bacteria causing the infection," he said. "Next, we'll start empiric antibiotics that cover the most likely pathogens." He prescribed amoxicillin clavulanate, 875 milligrams orally every 12 hours, explaining that it would provide broad-spectrum coverage against Staphylococcus aureus, streptococcal infection, gram-negative bacilli, and anaerobes. If the cultures reveal specific pathogens, like MRSA or Pseudomonas, we'll adjust the antibiotics accordingly. Dr. Carter also emphasized the importance of wound care. "We'll clean the wound thoroughly, and I'll schedule you for debridement to remove any dead tissue," he told Mr. Thompson. "This will promote healing and prevent further complications." Before they left, Dr. Carter addressed their concerns. "If your condition worsens, if you develop a fever, chills, or confusion, come back immediately. Those symptoms could indicate a severe infection requiring intravenous antibiotics and hospital care." 3 days later, Mr. Thompson returned for a follow-up visit. While the erythema around the wound appeared stable, the culture results had arrived, revealing MRSA, resistant to beta-lactams. Dr. Carter met with Mr. Thompson and his wife to discuss the results. "We'll need to adjust your antibiotics," Dr. Carter explained. "I'm switching you to doxycycline, which is effective against MRSA. This should target the infection more directly." He reassured them that since Mr. Thompson showed no systemic signs of illness, they could continue treating him as an outpatient. Dr. Carter also took the opportunity to reiterate the warning signs of a worsening infection. "If you notice any systemic symptoms or if the wound doesn't continue to improve, let me know right away. We'd need to escalate care with intravenous therapy if that happens." Over the next 2 weeks, the swelling subsided and the redness diminished. With proper wound care and targeted antibiotic therapy, the ulcer began to heal, showing healthy granulation tissue. At his final follow-up, Mr. Thompson walked into the clinic with a noticeable spring in his step. "I can finally walk without pain," he said, smiling. His wife added, "We're so grateful for your careful guidance through all of this." Dr. Carter performed one last check and confirmed the infection had resolved. "The wound is healing nicely," he said. "Keep up with your diabetes management and follow the wound care instructions we discussed. Preventing future ulcers is just as important as treating this one." After Mr. Thompson's case, Dr. Carter gathered his team to reflect on the key lessons learned. He explained that diabetic foot infections are classified into 3 categories based on their severity. Mild infections involve localized erythema of 2 centimeters or less without systemic symptoms and are typically managed with oral antibiotics like cephalexin. For patients with risk factors for MRSA, trimethoprim sulfamethoxazole can be added. Moderate infections, like Mr. Thompson's, extend beyond 2 centimeters or involve deeper structures such as muscle or tendon. These require broader spectrum oral or intravenous antibiotics, such as amoxicillin clavulanate, with additional coverage for MRSA or Pseudomonas if needed. Severe infections, characterized by systemic toxicity like fever, tachycardia, or hypotension, demand aggressive intravenous therapy combining agents like vancomycin and piperacillin tazobactam to cover MRSA, gram-negative bacilli, and anaerobes. Dr. Carter emphasized that empiric therapy must always be adjusted based on culture results to ensure effective treatment. He reminded his team that proper wound care, including cleaning, debridement, and offloading pressure, is just as critical as choosing the right antibiotics. Treating diabetic foot infections isn't just about curing the infection, he concluded. It's about preserving mobility, preventing complications, and ultimately improving the patient's quality of life.